Welcome. This is going to be the first of several installments to cover GU in pediatrics. First lecture, we're going to go over basic A&P, um, differences between kids and adults, some diagnostic tests that we're going to be doing. And then in the next lectures to come, I'll go into different defects, disorders, and things of that nature. So to start off, the overview of your GU system. So remember that this system is divided into upper and lower urinary tracts. Your upper tract is going to be your kidneys and your ureters. The lower tract will be your bladder and urethra. The kidney is a bean-shaped organ, one of which is on each side of your spine. They're about the size of an adult fist, and they're proportionally larger in infants. Position, the left kidney is higher, it's closer to your 12th rib, and the right kidney is lower because of the liver. The location, these are retroperitoneal. The structure, the outer region is the cortex, and this contains our glomeruli and our tubules. And then our inner region is the medulla, which contains the renal pyramids and portions of the tubules. And then we have our renal pelvis, which is located at the hilum and connects to the upper end of the ureter. Your ureters extend from each kidney into the bladder. As the bladder fills, it compresses the distal ureters to prevent urine from refluxing. Your urinary bladder is considered a hollow organ that allows for expansion, and it stores urine until we have excretion. Urethra leads urine from the bladder to outside the body. It contains an internal and external sphincter that control urination, and the male urethra is longer than the female urethra, which is why women are more common to get urinary tract infections than men. The nephron function unit of the kidney, each kidney contains about 1 million nephrons. They're responsible for filtration, reabsorption, and secretions of substances to form urine. The nephron structure, we have our Bowman's capsule, which is surrounded by glomerulus, which is the site of filtration. We have the glomerulus, which is a network of capillaries where the blood filtration begins. In the proximal tubula, we resorb water, ions, and nutrients. In the loop of Helen, this creates concentration, graduate for urine concentration. In the distal tubule, we have fine tunes of ion and water balance. And then our collecting duct is the final site of water reabsorption and urine concentration. Blood flow to the kidney. So blood flow to the nephron, blood enters the kidney via the renal arteries that branch off of your abdominal aorta. Renal arteries divide into afferent arterioles and feed the glomerular capillaries. Glomerular capillaries drain into the efferent arterioles. Filtration pressure, the afferent arteriole is larger diameter and the efferent arteriole is smaller in diameter. The size difference creates high pressure in the glomerulus, enabling filtration. In our peritubular capillaries and our venous return, your peritubular capillaries surround the proximal tubule, the loop of Helen, and our distal tubule. This allows exchange of water and solutes within the nephron structures, which then drain into the venous system, to the renal vein, to your inferior vena cava, and then back to your heart. The formation of urine. So glomerular filtration is the first step in urine formation. Blood filtered through the glomerular membrane. The normal glomerular filtration rate, or GFR, is 125 mLs a minute. It filters water, electrolytes, and small particles. Large particles like blood cells and proteins cannot pass. And then we have tubular reabsorption, which is the second step in urine formation. 99% of filtered water returns to the blood. Occurs mainly in that proximal convoluted tubule. It's regulated by our vasopressin, ADHD, and our aldosterone. Maintains about 1 to 3 liters of daily urine output. Tubular secretion is the final step in urine formation. It removes additional waste products, regulates acid-base balance, maintains electrolyte balance, and occurs in the distal convoluted tubule. So your key regulatory hormones is your antidiuretic hormone, which is your ADH, and your ADH controls water reabsorption, and it makes your tubules permeable to water. Aldosterone controls sodium reabsorption, influences potassium excretion. So our final components of urine are water, waste products, excess solutes, concentrated substances, pH balancing component. A little bit more about our hormonal functions. So all three functions become affected, especially if we have kidney disease. So we can have hypertension due to renin dysfunction, we can have calcium imbalances with the vitamin D, and we can have anemia from EPO deficiencies. And we're going to talk about each one of those individually. So renin production and function is released when blood flow pressure volume decreases. It triggers a production of angiotensin II. Angiotensin II affects, constricts blood vessels, increases blood pressures, and triggers aldosterone release. Aldosterone increases sodium reabsorption, which will result in increased blood volume and pressure. Vitamin D metabolism. Kidneys perform final activation step process. Initial synthesis is in the skin, so sunlight exposure. And then first hydroxylation is in liver, and first activation is in kidneys. This creates an active form. Function is essential for calcium absorption, regulation of calcium balance, and enables intestinal absorption of phosphatase. With vitamin D, it can be obtained in our diet and then also by the UV exposure of our skins. In the kidney, vitamin D is converted to its active form, and this can be used for calcium absorption in the gut. Erythropoietin production, this is produced in response to decreased oxygen. So when your body doesn't have enough oxygen, it stimulates red blood cell production in the bone marrow. Normal production is about 2.5 million red blood cells a second, and it can actually increase all the way up to 17 million in cases of anemia, low oxygen, or even high altitude. Kidney failure reduces your EPO production, causing anemia, and we can use synthetic EPO with chronic kidney disease. Now we're going to talk about some tests like the urinalysis. In urinalysis, I had to divide onto 2 slides. So I'm just going to talk about this one, and then you can pause over the next slide if you want. So urinalysis key components, collection, timing, and methods. First of the morning void is ideal. Later specimens might be too diluted for what they've consumed. Clean catch is preferred, and that would be during the midstream. So the patient would clean themselves, void a little bit into the toilet, and then continue to void in the cup. Children, that's a hard thing for us to get them to do, and sometimes even with adults, it's difficult. If it can't be processed or sent to the lab immediately, we should refrigerate it. Physical characteristics. Your color should be, a normal yellow. It should be clear without any sediment in it. So it should be, for clarity, clear. Odor, maybe a small faint smell of ammonia, but it shouldn't be foul smelling or too sweet smelling or too ammonia smelling. Those would all be signs of some type of process occurring. Specific gravity, normal ranges from 1.005 to 1.030. High indicates concentrated urine. So if it's high, we're thinking dehydration, decreased kidney blood flow, SIADH, right? Syndrome of inappropriate antidiuretic hormone. Low indicates diluted urine. So, are we having a high fluid intake? Are we using diuretics? Are we having some type of kidney disease? pH, a normal range of pH is different than a normal pH of blood. It is 4.6 to 8.0, averaging about 6. They consider it acidic if it's less than 7, and alkalotic if it's more than 7. It's easily affected by our diet, medications, acid-base balance, and kidney function. When we look at protein analysis, protein is normally absent in our urine. An indication, if it's present, could be infection, inflammation, or glomerular damage. Persistent proteinuria or protein in the urine needs further investigation. Additional components that we can look at could be nitrates, which occurs when bacteria is present, leukocytrate, estrase, which would be infection, white blood cells, red blood cells, glucose and ketones. Specimen handling, always cover the specimen, process within an hour, refrigerate if delayed, avoid contamination, and of course, proper labeling. And this is that other slide that just goes over some of those. So looking at a urine culture and sensitivity. The purpose of this is to identify the specific organism causing the infection. It determines what antibiotic treatment we need, as well as confirms that they have a urinary tract infection. So we need this and an accurate collection of this for appropriate treatment. Specimen collection, clean catch midstream, again, is preferred. So they would have to clean themselves and then void a little bit into the toilet and then continue to void in the cup. If we're not able to do the clean catch, then we may be required to do a catheterization where we just go in, collect, and then come out. Um, they like to have at least 10 mLs for accurate. Anything less might be insufficient for culture. Diagnostic criteria, a UTI is confirmed when we have a colony forming of bacteria. Sometimes we can have asymptomatic presentation, and we see that more in our older adults than in kids. We can also have multiple organisms in low counts, which could be suggestive of a contaminated specimen. For sensitivity testing, exposures, bacteria to various antibiotics. So if you have like a bacterial resistant urinary tract infection, again, it's going to determine what type of antibiotic is going to be most effective for it and identifying those resistant organisms. That aspect, the sensitivity testing, is really important if we have somebody who's a complicated urinary tract infection, somebody who keeps getting infections, a lot of our elderly patients, or if we just have somebody that's like really treatment resistant. Timeline, initial results take 24 hours. So you'll usually see a report saying these are your preliminary results. Complete sensitivity results take longer. Most of the places I've worked at, it's usually 72 hours for that complete report to come back. But depending on your location and your equipment, could be longer. Indications for testing. Again, if we have somebody who has recurrent urinary tract infections where we're getting like 2 or 3 plus a year, if they're complicated, I'll discuss more in other slides. If they're not responding to standard treatments, or if it's a questionable diagnosis. Serum tests. So we can do a few serum tests to assess our GU. status. We can look at renal function. So what's their BUN? What's the measurement of the protein metabolism byproducts? It's going to be elevated and decreased glomerular function. It affects the protein. It can be affected by protein intake and hydration. Serum creatinine measures your skeletal muscle waste products. It's more sensitive for renal impairment, more consistent excretion than the BUN. The BUN and creatinine ratio, normal range is 6 to 25. This helps assess um, fluid volume status. It really gives us a good indicator of kidney function. When we talk about our glomerular filtration rate, which is our GFR, normal is greater than 60. This can be a very key indicator of renal function. It measures kidney filtration capacity. Other tests we can do is a CBC, which could be detecting anemia, possible infections, and monitoring of our blood components. Our electrolytes, how are we doing with sodium, potassium, and calcium? Because all of those might not be getting excreted properly if our kidneys aren't working. And then clinical significance. So monitoring kidney disease progression, it'll guide treatment decisions. It can assess for medication effects, if it's working the right way, and overall evaluation of your fluid and electrolyte status. So these are going to be imagings and tests that we can do to kind of more further assess that GU. We can do just standard x-rays that will provide us kind of those abdominal structures. Some people can diagnose kidney stones with an x-ray. CAT scans provide us with a little bit better imaging. They can reveal kidney stones, renal tumors. We can do a DMSA renal scan. This is using radioactive material, and it evaluates blood flow and renal function. It can also assess renal scarring and pyelonephritis. A renal ultrasound is a great non-invasive way to determine position, size, and contour of the kidneys, ureters, and bladder. It can detect obstructions, renal stones, possibly. And it's also good if we're going to be doing a localized renal biopsy. A cystoscopy is a lighted kind of telescope lens that goes in through your urethra up into your bladder, and it shows us a visual of your lower urinary tract. And this is useful for visualization of tumors, removal of stones if they've dropped into the bladder, biopsy of bladder tumors, and then avoiding cystothoragram. BCUG uses contrast dye instilled into the bladder. The child or infant voids after the bladder is filled and a serial films are taken. This will help diagnose if we have reflux, that urine is flowing back into the ureters and its severity of it, if we're having bladder emptying problems or even urethral problems. So now looking at specific differences between, peds and adults. When we look at children, kidneys occupy a larger portion of their posterior abdominal wall. They reach adult size by adolescent. Weight increases fivefold from birth. All nephrons are present at birth. No new formations occur. We have a 90-degree rotation during our fetal development, and they ascend during development to L1 area. Your bladder is located higher in the abdomen during infancy, closer to the abdominal wall. Cylindrical changes to the primordial with growth, gradual descendants into the pelvis, and may not void for 12 to 24 hours after birth. Ureters, proportionately shorter than adults, length increases with growth. Development timeline, urine formation begins 3 months gestation. contributes to amniotic fluid. Glomerular development occurs over 30 days. Development continues through the ninth fetal month. Clinical considerations, age affects presentation of symptoms. Renal abnormalities may link to other malformations. Failure to thrive may be indication of impaired function. Enuresis significant varies by age. Careful monitoring of intake and output is essential. Blood pressure monitoring is crucial. Our assessment for these kids. So, pediatric urinary assessment overview. Assessment's going to vary by age and development. Nurses must, excuse me, understand um, anatomic and physiological differences in children. Always compare finding to age appropriate norm. So, kidney function. Determine if kidney function is normal for the child age. Normal urine output is 1 to 2 milliliters a kilogram an hour. Decreased output may indicate impaired kidney function. Hydration status. Assess for dehydration or fluid overload. Skin turgor should snap back immediately. Poor turgor could be due to dehydration. Pitting edema could be fluid overload. Acid base, watch for signs of metabolic acidosis like nausea, lethargy, rapid breathing. We can confirm with a urinalysis or an arterial blood gas. Urinary tract infection, common pediatric concern. Look for dysuria, enuresis, urinary frequency, foul smelling urine. Confirm with a UA and a urine culture. Use age appropriate urine collection techniques. Bladder control, you always want to assess toileting status. Are they toilet trained? Are they in diapers? Are they having involuntary voiding or accidents when they were once normally dry? And then consider developmental norms when evaluating. Fluid balance assessment in children. So, frequent and accurate INO monitoring is vital to evaluate fluid volume status. Children with severe renal impairment may need INO measured every 1 to 2 hours. Fluid intake includes both oral and IV fluids. Urine output and recording. Normal would be that, greater than or 1 milliliter a kilogram an hour. Less than 1 milliliter a kilogram an hour is reported important to report immediately. It may indicate oliguria, impending renal failure, or just inadequate intake. Daily weights are essential for tracking fluid balance changes. Weighing using the same scale, the same time each day. Infants and younger children should be weighed without diapers. Older children just wear a gown. Respiratory assessment. Also take breath sounds every 4 hours. Watch for signs of pulmonary edema like rapid respirations, retractions, nasal flaring, and crackles. Fluid restrictions. Occasionally we order these. Limits may be ordered to prevent overload. We want to educate parents and visitors and staff about the restrictions. List favorite fluids on plan of care. Encourage gradual fluid intake, not large amounts at once. Provide only the allowed amount for each time period. Sodium and diet considerations. High sodium increases fluid retention. So low sodium diet, if it's prescribed, we need to make sure we're enforcing that. And then as well as reinforcing that dietary restriction with family and visitors. That is the end of this lecture. Next will be the beginning of GU disorders.